Hello everybody, my name's Dr. Helen Noble from Queen's University Belfast, and in collaboration with the EDTNA ERCA, we're presenting this webinar to you today. So we're so delighted to have so many of you join us. So welcome to this second EDTNA ERCA webinar, which is around a shared vision of COVID-19, and we're going to look at the experience of COVID-19 in renal units across the world. So this webinar is going to include experiences from the Kingdom of Saudi Arabia, Spain, Australia, and the United States. So I hope that you're all connected and that you can hear me properly. If you have any problem during the webinar, if you could use the chat box that you'll be able to see on the right-hand side of your screen, and our technical support will help you in any way that they can. I sincerely hope that you'll get the most from this online webinar. We've spent some time together with our presenters, pulling this together to make it hopefully very useful to you all. Be informed that the presenters will not be able to hear you when they're presenting, but you can type in your questions and comments on the box as I mentioned on the side. So do please feel free to ask any questions via the chat, and we'll answer as many questions as we can after the presentations. So just briefly to introduce our speakers, they will all introduce themselves, but we have Fiona Donnelly, who's presenting from Australia, and Fiona's the president of the Renal Society of Australasia and is currently a nurse practitioner candidate at the Renal and Transplant Service at the Royal Adelaide Hospital. And her career has been predominantly in haemodialysis. We then have Faith Lynch from the United States. And Faith is clinical nurse manager of the acute inpatient dialysis unit at NYU Winthrop Hospital. And she's currently pursuing her doctorate of nursing practice degree from Chamberlain University. She's also a really active member of the American Nephrology Nurses Association. We also have Reem Al-Hamidi from the Kingdom of Saudi Arabia, and Reem is a nurse consultant and Deputy Director of Nursing for Dialysis Services, and she currently has the role of EDTNA ERCA Brand Ambassador for KSA. And she completed her Doctor of Clinical Practice degree in 2017 in Southampton in the UK. And then finally, we have David Hernan Gasuina, I hope I pronounced that right, from Spain. And David's a nursing director in nephrology since 2005, and he holds an MBA. So it leaves me to say enjoy the webinar, and I will now hand you over to our first speaker, Fiona.
Thanks, Helen, and thank you very much for this opportunity to be able to share the experiences we have over here in Australia. As Helen mentioned, I've been working in renal for the past 29 years. I have just finished my master's nurse practitioner and just waiting to be credentialed, so I'll be working in that role very soon, but I've been working in multiple different roles in renal nursing, predominantly in haemodialysis. My discussion, or my topic today, is really going to be, so I'm going to be talking today about basically a collaborative approach that Australia and New Zealand put in place for the management of COVID-19 patients. Our experience in Australia and New Zealand was nothing compared to what it is seen by us overseas. So with watching everybody overseas, next slide please, we actually worked through developing a working group. So I'm just going to give you some data first that I've just put together. So when COVID-19 actually started, we started collecting this within the Australian National Data Registry, which is ANZ data. And these numbers are a little bit different now because there's been a further, a second wave in Victoria in Australia. So it is still 5 dialysis patients, but a total of 10 transplant patients that have been positive. None in New Zealand. And next slide, please. So as I mentioned, we I got a request from the Medical Association, which is called ANZSN, to get some nurses together from each state and from New Zealand to actually join together in a working group to develop some preparedness strategies for COVID-19. The membership also included Transplant Society of Australia and New Zealand, the ANZData, which is the National Registry, Kidney Health Australia, Kidney Health New Zealand, and so there was a lot of people on board, and we met in the first instance weekly. So part of the work was not just dialysis preparedness, but we set up focus groups, and part of the focus groups were actually looking at workforce. And what we did with workforce was put calls out to nurses across Australia and New Zealand to see if they were willing to travel to other states to see if, say, there was an influx of COVID-19 in those units or staff came down sick, and that we'd be able to travel. So that went out through the RSA, but we also looked at how you would manage your workforce strategies and I suppose with the stress levels, anxiety and everything else. So we've developed a workforce so preparedness sort of sheet for that. We talked a lot about PPE, which I will talk about a little bit later on. There was acute kidney injury, and then we did a lot of communication strategies which went out via our Kidney Health Australia and Kidney Health New Zealand. Part of the work that we also did was working through with dialysis suppliers and making sure that we had sufficient supply for dialysis, both for peritoneal dialysis as well as the hemodialysis. And there was also just discussion on the transplantation side of things. With regards to transplantation, with the first wave that we had here in Australia, transplants were actually put on hold and then resumed, I think, once that wave died down, probably about middle of April. Now with what's currently happening in Victoria, they have decided not to put that on hold, and basically it's continuing apart from one of the hospitals in Victoria at the moment. The ANZData registry is still continuing to collect data. Next slide, please. In relation to the working groups and the resources and things we use, these are the people we made contact with. We had a number of people, I suppose we had the medical staff actually contacted doctors in countries such as China and America, and they did little podcasts and they were played, and we actually saw and learned from their experiences. So they were part of what we did in there. We also used, especially for our preparedness thing, we used the template from the Centre of Disease, the CDC guidelines. Obviously, we shared all of the information that you all would have been using from the World Health Organization, etc., and our local communicable disease network in Australia and New Zealand. Next slide, please. This is just a brief overview of what the dialysis preparedness checklist included. And if you've seen the CDC one, it's fairly similar. We just adapted it to the Australian units. There's links down the bottom there which will actually link into both the RSA website, which has got all of the checklists and all of the information that is available there, and also for the ANZSN website. So there's some interesting information and data on there. Next slide. This has changed also since, as of yesterday, the actual PPE guidelines that we developed have actually been approved both by the Australian Infection Control Expert Group and the New Zealand National Renal Advisory Group. So they are available on that site that I just showed in the last slide. But we covered things like PPE for staff, for patients in the HD unit, the transport, also for unit staff and for patients. And there's some quite detailed guidelines within that. Most units, like you all have in all of your countries and all of your states where you are, we all are guided by our local guidelines as well as what is national. So most of us would probably have been doing most of these things anyway, but some of the things have been intensified, like the use of masks. Next slide. So I just will add, before I hand you over to Faith, I'll just will add one thing from my experience locally in South Australia. We actually made the decision to actually close a dialysis shift on a Monday, Wednesday, Friday morning and afternoon and move those patients out into the local areas in the satellite units across South Australia in the metropolitan area. The hospital I worked in was the COVID-19 dedicated hospital, and the reason we did that was so that we had somewhere to dialyse if we had anybody that came in positive, and the unit was designed then to be thorough clean before the afternoon, before the next day, the Tuesday, Thursday, Saturday shift came in. And that was gradually reopened and it's fully opened again now. But we know now that we can actually move that way if a second wave came towards South Australia and we needed to actually accommodate multiple cases of COVID-19. So as I said, our experience is nothing like what you guys have had to deal with, mostly to do with preparedness. Thank you for your time. Next slide, on to Faith.
Hi everyone, my name is Faith Lynch. I'm just gonna, hold on. I am the nurse manager of the inpatient dialysis unit at NYU Winthrop Hospital in the United States in New York. Next slide, please. Oh, thank you. Okay, so I'm gonna talk to you guys more about like a clinical experience and what we experienced over here in New York. So I'm going to start in the beginning. So in the United States, our first COVID positive case was on January 19th in Washington State. That was for the whole entire United States. And in New York, which we were considered a hot spot, our first case at my hospital was on March 6th in 2020. In the United States right now, we have 3.9 million COVID positive cases as of yesterday, and about 145,000 deaths. In New York alone, we had 412,000 cases and a total of 32,000 deaths. So we're a little bit more ahead of Fiona in Australia and stuff. So, but so for preparation for COVID as a whole, the hospitals, all of them in the area, were converting all their space that they had into ICUs, and we have a conference center in our basement, and that was turned into an ICU. All the procedural areas in the hospitals were turning into ICUs. So a little bit different experience here. Right now, New York is on a down spike, and the rest of the United States is spiking. So right now we're okay, but the rest of the United States is getting busy. The hospitals did put tents outside to accommodate ER staff. So we kind of out of nowhere just were inundated with patients, where I'm in a 591 bed hospital and we had over 400 positive patients at one time in our hospital. So I think, you know, it's just so different in so many different places. But next slide, please, because it's not working. So I'm going to talk about a little bit in the in-hospital acute dialysis setting. So all of our COVID positive patients, or our patients under investigation, which they call PUIs, were patients that we ended up having to dialyze bedside on a one-to-one with a dialysis nurse, only because the unit that we have isn't negative pressure. So we couldn't really bring those patients to the unit. So we were doing all of them bedside. And I could say that we noticed like an alarming number of patients developing AKI in the hospital. And we were not expecting all of this kidney failure. I don't know if what you guys are seeing in your areas, but of the critically ill COVID positive patients, about 25 to 40% of them developed AKI. The symptoms that we were seeing, so the majority of the symptoms that we saw when the patients came into the hospital was volume depletion. So obviously most likely due to fevers and diarrhea and chills and all of the other symptoms that they were having. But they had severe, sudden, acute kidney injury with life-threatening hyperkalemia. So the potassium levels were probably between 8 and 9, and we were just trying to correct those potassiums with dialysis, and it was just very, very, very overwhelming. These patients are being dialyzed on demand, and we would see a trend in the hospital where the patients were admitted, and within 8 to 10 days, they would become hyperkalemic, have AKI, and then they were intubated. But these were of the critically ill populations. We did RRT therapy, we did CRRT, we did intermittent HD, and we did try a few acute PDs to try to help with the overwhelming amount of patients that were in kidney failure. But with CRRT, we were kind of cycling these patients 12 hours on, 12 hours off, because we just only have so much equipment. So we were doing the best that we could to make sure that everyone got what they needed. The mortality rate was about 70% of those patients that were on CRRT. How do these patients tolerate dialysis? I'm gonna say the hemodynamic stability of these patients was very poor. A lot of them were hypotensive, needing so many medications for blood. And dialysis patients are so different. I think their hemodynamic stability is seen completely different through the lens of a dialysis nurse. I think we as hydrated and then ends up intubated in kidney failure on so many medications that they're now fluid overloaded. So we're trying to keep them euvolemic, which was so very, very hard. We had to make a decision in our unit to cut dialysis treatments like 2.5 hours just to get through the amount of patients that we had in the hospital at one time for dialysis. So next slide, hold on. Can we do the next slide? Next slide. It's not working. No. The next slide, it's not working. Thank you. Oh, okay. Okay, thanks. So I could just give you a little bit of our outpatient dialysis guidelines and what the CDC stated for us to do. So in the outpatient dialysis units, they were cohorting patients on different shifts or on the same shifts. Any patient that was suspected to have COVID was cohorted separately from confirmed cases in the general population. The dialysis centers approved should make every effort to transition patients who are willing and able to receive dialysis at home. And they were also screening patients before dialysis. I can say that we did have an issue with allocation of supplies for dialysis in the United States. So we needed more equipment, and I know we were running out of cartridges and dialysis machines. And I think that dialysis nurses in general were something that people didn't realize they needed so much of until COVID-19 hit, because we're a specialty, and you know, there's not many of us in every hospital, every setting. If you think about it, like in a hospital of 4,000 employees, there may be 6 dialysis nurses. But when it comes to equipment, we all know that N95s were an issue, but dialysis machines were also an issue. So I could say that the government, with the Department of Health and Human Services, what they did was they purchased 50 Tableau dialysis machines from Outset Medical, and they actually got them last year for the hurricane season. And thankfully they had these machines, so they were able to give them to about 12 hospitals in New York. So we were able to get more dialysis machines to be able to dialyze these patients. So that was really great. Next slide. So the nephrology nursing staff. So American Nephrology Nurses Association, President Lillian Pryor and the board of directors and the national staff came up with this interactive map for all of us to be able to go on and click and see, and we were able to put like our needs for our hospital. So it was actually a really great tool. I actually utilized it. So I was able to go on under New York, click the tool, put my hospital and say that I needed registered nurses because they needed to get traveler nurses because we were so inundated. And they actually put up all different resources and support. And it was actually a really good tool because I got phone calls from different nurses saying, hey, do you need me? I can come to New York and help you out. So it kind of really brought the nephrology nursing community together. And it was a really good support from our organization. The mental health and well-being of the staff is very, very important. And I can tell you that being in the situation and walking through those units and dialyzing those patients, it was really something that like you never want to go through again. It was just such a dark period, I think. You're walking in these units, you're trying to dialyze these patients and they're prone, vented, and all you hear is everyone calling for a nephrology consult. You don't N95s because we were in those rooms with these patients for like 3 to 4 hours. So obviously N95s were protecting us from contracting COVID-19. So next slide. Thank you. So how do we survive the first round? We did a lot of teamwork. I have to say the nurses were working 16-hour days, 6 days a week, coming in to do what was best for the patients and for their coworkers. And we're just prepping for a second surge now because it seems like it's coming back up the East Coast of the United States. So we're getting ready. We have all of our equipment. Everyone's trained on all the new machines that we have. We have enough supplies now. I haven't heard any issues, and staffing is just to be seen. I mean, we just got to train more nurses and get more traveler nurses. So that's kind of how we functioned here in New York. But thank you.
Yes, hello. Yes, good morning. Well, first of all, I want to thank the EDTNA, SEDEN, my Spanish society, and my company FIAT to be here talking to you. Well, I'm David Hernán Gascueña, Nursing Director at the Fundación Renal Íñigo Álvarez de Toledo, my company in Spain, and I also have the role of the institutional relationship with other societies, the Spanish Society of Nephrological Nursing. I am the nursing director in my company. I also have publication and several things. I also have studied business administrations, but I am a nurse. Well, next, please. Yes, I'm going to talk about the impact on Spanish renal patients. These figures are until the 4th of July this year. And as you can see in this curve, infection curve of the incidence of renal patients in Spain, it follows a similar behavior with the Spanish population infected also with COVID-19. As you can see, we have suffered seriously during the months of March and April. But since the beginning of May, the infection has restrained, fortunately. Oh, before, yes. The impact has been different in Spain. In the whole country, the allocation has been variable. the greater impact has happened in Madrid and Barcelona, probably because the virus came from the biggest airports with connection flights to China or Italy. But you can see Madrid, 36%, for example. Well, the incidence in all Spanish patients has been 1,735 patients. That means the 3.1% of all renal patients in Spain. 65% were on hemodialysis, and also a big amount of percentage were transplanted, 31% of all patients infected. And 27% of those patients have deceased. That's horrible. That's one, it's more than 1 out of 4 patients. I think it's a horrible number. Well, as a comparison, this is a registry for my company, also in Madrid. We have 8 dialysis units, hospitals and no-hospitals units, with almost 800 patients. We had 10% of infected patients with a 25% of deceased patients. That figure matches with the general one, but the infection in all Spain was at 3.1, but in Madrid was bigger. So in Madrid we have the biggest impact. So, but at the end, the 25, it's similar to 27% of patient deceased infected with COVID. Well, what else about these patients? The patient's typical profile infected with COVID-19 is a patient old. He's 68 average years old. 2 out of 3 were men. 1 out of 4 are diabetics. And most of them had to go to the hospital, 83%. 3 out of 4 developed pneumonia, and almost 10% went through intensive care units. That's the double as the rest of patients, no renal patients in Spain. It's approximately approximately 5%, but in renal patients, the double. And they needed almost 20 days as average to recover from the illness. Well, the measures taken at the dialysis centers. In my company, Fundación Renal, we implemented a protocol from the 2nd of March, but it was confirmed by the protocol developed by the Spanish Societies of Nephrology, made by nurses and also made by nephrologists. And these measures about everything, about, for example, infrastructure, and first of all, as we have listened, the triage, and also with a small anamnesis, talking to them, even making them phone calls, especially made by the supervisors, and the use of hydroalcohol every time and everywhere. That has become a good habit that didn't do properly before the COVID-19. That's a good. There are a few consequences, good consequences, but this is one, because I was fighting to use the hydroalcohol, and now there are no doubts with that. It is essential the use. Oh, sorry. Alcohol, yes. Yes, sorry. We have tried to separate patients when it was possible during the dialysis sessions, not in all centers, not in all, it depends of the rooms, but we need to separate them as far as we could, as far as we can. The use of personal protective equipment, it is essential, in my opinion. The mask is mandatory and essential to avoid spread, and for the staff and for patients, for everybody. A room special for COVID-19 isolated is essential, and also special rooms for patients with doubts. We have doubts, so if they have COVID or about the symptoms, the doubtful patients, I mean, and if we not if we have not a room for them, at least we have to separate them from the rest. For me, it was shocking to know that there were patients that didn't want to recognize any symptom of COVID to avoid going to the hospital. During those days, in the beginning especially, they thought that if they went to hospital, they would die. So they were really scared. What else? Patient education. It is essential. It's an essential labor made by the nephrological nursing about education, awareness, about to know and to detect early the early detection symptoms. Sorry. To learn to do the education with the correct use of. I have put EPI. Sorry, it's a mistake. It's PPE. That's in Spanish. I couldn't translate it. The correct use and how to use them and how to take care of them. And in general, all kind of prevention measures. All of this, especially at the beginning of the pandemic. But any time, remembering everything. And we don't know, and we will never stop to do the education with the COVID, because unfortunately this hasn't ended. Okay, what else? What more measures? Sorry. Okay. Oof. Yes. Measures to be implemented by nursing supervisors to collect the PPEs and the dialysis material in general to avoid to be run out of stock. The PPE control also, especially for the theft prevention, because at the beginning of the pandemic, robbery of PPEs was significant. And to increase the cleaning frequency, the number of hours, we have to clean a lot. Especially objects frequently touched by the staff and patients, like scales, doors, doorknobs, toilets, tables, computers, computer mouses, kitchens, everything must be cleaned. Also, do not allow meals during dialysis sessions. That's a hard nursing labor of pedagogy, because it was hard for patients not to eat, not to drink, nothing. And we had to suggest them not to travel. Well, traveling was forbidden at the beginning, of course, but it was another hard thing to understand for patients. Now it is not recommended, but we leave them if they are controlled, if they have all the tests done, but it is not recommended even yet. To prohibit meetings, trainee students, presential gathering of people in general. Also with the staff, the nurses can join others during breaks or coffees, or at least with the social distance, the security social distance, at least, because if they are eating or they are drinking, they take off the masks. And the use of disposable material to avoid any kind of object handling. Well, what else? This is a new from Spain. It is more than 74,000 nurses have been infected with COVID. That means 7.4% of all nurses in Spain, but all kind of nurses, not only dialysis nurses. But in nephrology, I'm going to compare it. This is a study of my company. My company is a only dialysis company, and it is not a 7.4% of nurses infected. It's the double. It's almost a 14% of nurses were, well, nurses, dialysis staff also doctors, also people who help nurses in Spain. I don't know the meaning. I don't know exactly, but everything who works with renal patients in the units of my company. And so almost 14% of all those people were infected with COVID during this period of time. And 9% of them felt any kind of symptoms. The rest were, they didn't feel symptoms, but they were infected. Yes. Well, and what else? What has happened with the dialysis nurses in Spain during this period of time? They have had a minimum contact with the patients. Almost they only had contact in connection and disconnection, a close contact. It was hard for nurses and also for patients, of course. Also ignorance at the beginning, especially caused by the lack of knowledge, anxiety, and other suggested COVID-19 symptoms like headache or dyspnea, fear to be infected or to infect your relatives at home. That was very important. Sick leave with enormous problems to cover the sick nurses. So in Spain, we have few nurses. So you are all welcome to come to Spain to work here with us. With a high workload, everybody had to cancel holidays, days off, everything. And that meant stress and fatigue. But those are bad things. As Fed has said, also there are good things, like, for example, the teamwork. Teamwork has been great during this period of time, and I hope it will continue for the future. I'm finishing with the future. The mistakes to avoid in the future that I think or I see that has happened. The covered use of personal protective equipment in patients and nurses during dialysis. No, but not during dialysis. Always, even at home, at holidays, with our friends, with our relatives. Always we have to use the correct use of personal protective equipment. A close monitoring of patients from old people's home, because most of them have disease. Not most of them, but the biggest percentage of renal patients deceased by COVID were from old people's homes. Or if they haven't died, they could have infected the rest of patients. And a quick isolation of positive patients, or even with symptoms or doubts, until the test, the PCR or antibodies are done. We need to move fast, or at least faster than we have done in the past. We have to encourage to avoid collective transportation or any kind of clustering places where the patients can be infected. And that's all. I hope you have liked it. Thanks for your attention.
Hello, hi everyone. Thank you for this opportunity to participate with our experience here in Saudi Arabia. As Dr. Helen said, I'm Dream Al-Hamidi from King Abdulaziz University Hospital. I have about 20 years experience in nephrology nursing, pediatric and adult peritoneal hemodialysis. I'm the Director of Nursing for Renal Service in this organization, and I will share with you our experience in our small unit and during the COVID-19. Can you have the next slide, please, Susan? Yeah, so to start briefly, I just want to say that in Saudi Arabia, we didn't hit hard by COVID-19 because of the measure that we suspend the travel to the two holy cities, which is the largest gathering in Saudi Arabia, Mecca and Medina. So the first case was confirmed positive COVID-19 was in the 2nd of March 2020. It's only until March. So, but here in it wasn't until 13th of May that we have the first positive COVID patient confirmed in our hemodialysis patient, and it was one of our outpatient patients, outpatient dialysis. Can you have the next slide, please? So what we've done as a whole organization, because it's a big university hospital, and we were like a backup for the Ministry of Health in the Western region. We had a big, once we had the positive cases, the clinical skill and simulation center started to do frequent courses of DBE, how training workshop for all healthcare workers, how to do the donning, the doffing. The N95 fit test was every day. We have an updated list of the people who have their N95 fit test available. This is one of the pictures early on when I was participating in this workshop. So that helped us to get really prepared when we have the patient. We are all meeting in the hospital was transformed into a virtual meeting and no gathering. And we have a search plan committee for the nursing, admin, and part of the whole hospital plan, how we move the unit, how we move the nurses from unit to unit, and how we all started to open the isolation 2, 3 on according to the needs, and ICUs as well. At that time also we started a psychological support group for nurses. I wasn't personally part of it, but it was done with my colleagues, that the nurses, they will have a regular meeting virtually to discuss their worries, their anxiety, their fear, their stress, what is the update, because we have very multinational workforce, and some of them, they're stranded back in their country, or they have their family or their loved one there. So we try to keep them all updated and contact and whatever is the information. Next slide, please. So in dialysis, we had a dialysis search plan. First of all, this is the triage room. We separated the pathway for entry for hemodialysis for COVID-19 patients. We have two pathways, one for the clean cases and one for the confirmed cases. Visual triage screening with to assess the risk criteria for everyone who entered the unit. It was already a restricted area. So all staff, all patients, all relatives who coming to hemodialysis, staff, medical students, even maintenance, they will have to go and do the visual triage and temperature and ask for symptoms. Patients on peritoneal dialysis were advised to call before they come to peritoneal dialysis if it's urgent, and if they have symptoms, they were advised what to do. We suspended a 2 months, I think, the BD clinic. So the patient were followed virtually. Signs and poster of proper hand hygiene, hand sanitizer, mask wearing were requested everywhere in the dialysis unit or in the hospital. So we have these posters in Arabic for the patients to understand how to use the hand sanitizer, for how long the hand washing, the reminder for the staff also how about the mask. Social distance were placed at the reception area, entrance, like you can see the signs that individual tries that, because we prevent people to be crowded in the entrance. So we have these signs to remind them. We dedicated one dedicated nurse for visual triage, so she can be only sitting in that area, so we don't have anyone coming into the unit. Limit the patient visit and minimize waiting area, waiting times to prevent crowdedness. Actually, some patients used to come earlier before the dialysis session, so we advise them to come exactly on time before they used to come before and sit and gather in the waiting area. with the start of the pandemic globally, we minimized that, and we advised them to come on time, and we limited the visit. It was restricted in the hospital, but in a really rare case, we allowed someone to visit during the hemodialysis. Next slide, please. Nurses' point of view. This is one of our isolation nurses. Staff nurses' duty schedule were divided into two different teams. We worked into two different teams, A and B. So a group of nurses, we divided by 50 basically, doctors and nurses. And this is all over the hospital, not in renal. So group A will work for a week, and then the next week, group B will come and take over the endorsement and handle the cases. This is works in the beginning, but when we start to have more cases, and we had to work at full capacity, so we went back to work with full capacity of nurses and healthcare workers. Applied social distance in the offices, like everybody says, in the staff room, and we applied a sign for the coffee room in the nursing coffee room or lunch or coffee break. They need to be social distancing sign there, and in the accommodation, in their accommodation and compound. Hand hygiene, the use of alcohol-based and hand sanitizer, and wearing mask at all times. There was a sign everywhere to remind everybody, and how to use also the supplies, the BBEs. We have a BBE officer to see how we use these supplies for cases. Staff with chronic medical condition were exempted from coming to work. Whoever have their immunosuppressed disease or they were in chemotherapy, they went from the early of the pandemic till now, obviously, and compulsory leave, or who were pregnant, they were not supposed to come to work, and that's officially. We had toward the end to deploy hemodialysis nursing staff to work in ICU because they have ICU background, to help in the new extended ICU unit that we had to open as of our hospital surge plan. And to back them up in our hemodialysis unit, we deployed our peritoneal dialysis nursing to work in the hemodialysis, because we already have a routine of deployment between nurses, peritoneal dialysis and hemodialysis nurses to do to have deployment for course training, and they done all the competencies, so that helped us a lot. Recently, 2 weeks ago, we had to start a third shift extended, especially for COVID-19 patients, to accommodate them, because we have only 2 negative pressure rooms in the unit. And once we receive the HEPA filter, mobile HEPA filter, we will start to, inshallah, use it for the third shift and cohort patient whenever we need it, when the number is increasing, inshallah. Next slide, please. Yeah, thank you. This is one of the pediatric kids. He always in our photo in conference. He was due for transplantation, but it was delayed. Hopefully, after everything settled, he will continue with his process. Thank you.
Thank you. Thank you all so much. That was just a fascinating description of a cross-country experiences of COVID-19, and it just demonstrates how the different experiences that nursing staff had across the world. And I'm sure we've got many people from other countries who are listening in with similar or very different experiences. I want to apologise for any difficulties you might have had, any connection problems. There was a little bit of a mouse problem. The webinars are new to EDTNE ERCA, so because we had to cancel the conference, we were really trying to put together a series of really innovative and interesting webinars, but it's a learning experience for everybody, so we'll get better each time. So I do apologise if you had any issues, and I hope it didn't upset your experience of what was some very excellent presentations. It's so complex bringing people from across the world together. but I think we did well in the end. Okay, just to let you know that this whole recorded video will be available online via the EDTNA ERCA website, and the first webinar is available via YouTube, so I believe it will be on a YouTube link, which is great because it's so easy to share YouTube, and it's great to have the experiences out there shared across the world globally. So we will make all of that available, and we will let you know exactly where to go, and I'll talk about evaluation later on. But this is now a chance for questions. So hopefully you've got lots of questions that you perhaps want to ask of the panel. And what I would ask is that you start typing in the box on the right-hand side if you haven't already, and we'll start to take a series of questions to the panelists. And as those questions arise, I will be able to share them with everybody. Okay, so in the meantime, whilst those questions are coming to me, I have some questions. Let me think, who will I start with? Fina, in Australia, you mentioned the very early stages of the COVID pandemic, talking to your international contacts, which was really interesting because you're much closer to China than we are. And I just wondered how that worked and how helpful that was.
So that was actually a nephrologist to nephrologist, and they did a podcast. It was very useful. It was actually very interesting to hear their experience. They talked about mainly, unfortunately, more about the acute kidney injuries than the dialysis and anything else, but they talked a lot about PPE. So that was the first one. And then I think they linked in then again with someone in America as well, but I'm not sure which state it was or who it was. So I missed that presentation because they were weekly. So we had weekly kind of, on top of the working group meetings, we actually also had sort of forums where there was discussion. So we could actually, as a whole, between nurses and medical staff, decide what was important factors to talk about or bring up at the next meeting or address. But they were actually very useful, especially the one from China.
Okay, good. Okay, that's really helpful to hear. And Faith, in New York, I just had, you had a terrible time to hear that you had 591 beds and 400 positive patients at one point. That's just such a huge and frightening number. It just kind of puts it all in perspective. And then this huge number of AKI admissions of up to 40%, so almost half the hospital. But you mentioned the PD experience. So you said that peritoneal dialysis was used to try and manage some of the AKI coming through. Was that right? Can you tell us a little bit more about that?
Yes. So the physicians kind of tried to do more acute PD on some of these patients, just because we were having machine shortages, and they wanted to try something different. If a patient was stable, they were like, okay, let's try to put in a PD catheter and see. And we actually had 3 or 4 patients that they did acute PD on, and they did well. So that was good. They did well, yeah.
Okay.
So
there is the possibility of a PD approach. I know it's not vastly utilised and these patients are very sick, but it was successful for some.
it was successful, yeah. We only did it on a select few patients, but yes, it was successful. So that was good to see.
Okay. Okay. There's a question come in for David. David,
Yes.
do you think in Spain you're going to come back to this horrible situation that you had in spring? And this is because more positive patients are now showing up. So are you getting ready, I suppose, for the second surge that might be as bad as the first?
Sorry, can you repeat me the question?
Yeah, sure. Somebody's asked, David, you had a really awful situation in Spain, and they're wondering if you think this awful situation is going to return because you've got growth of positive patients, more positive patients. Are you going to see what you saw previously, do you think? What are you all expecting in Spain?
Well, I think that for sure it is not going to happen the same again, because we did it very bad. We have to assume that we were not prepared, we were not covered, we ran out of personal protective equipment. We didn't know how to prepare, to isolate patients at the first moment. I mean, and in general in Spain, there are places, there are hospitals that have acted better than the rest, but in general, patients, it was hard for patients to accept to use the mask, to go, for not going together in ambulances or in collective transportation, for not to travel, not traveling in general. So I think that the same is not going to happen again. And now we have controls. If we find any patient who has any kind of symptom of COVID, we move fast, and we do the PCR, the test, as far as we can for the first moment. And if the patient is positive, we look from the rest of patient who has been a close contact with him. The rest of patient, the staff, also at his home, with the relatives. So it's now it is better, right? Because in the beginning we had not the test. We could not do all PCR as it was needed, because we had no material. So in the future, it's not going to happen the same. I hope so. I can be wrong, but not so hard as we have suffered in the past.
Yes, fingers crossed. We're all a bit like that, aren't we? Just hopeful. It's all a learning experience. I know, it changes day to day. And this is another question, I suppose, for all the panel, but I know that you mentioned it, Faith, the reduction in dialysis hours. So some patients received less hours than would have been usual, or perhaps what they required, perhaps for you, David, as well. And I suppose just the ethical dilemmas really that were faced by the healthcare practitioners, or have been, or still are faced. I just wondered, had they been raised? How had they been dealt with? Any comments from anybody? I'd start, Faith. But
I can say that the nephrologists were not happy that we had to cut treatments, but we had to work together as a team to, every patient deserved care. Mm-hmm. So with the amount of patients that we had, if we had to dialyze them for 2 hours every day, at least they were getting some type of treatment. Our goal at that point was to treat those critically ill emergent patients versus those chronic patients that ultimately can survive with 2 hours and then get treated the next day for a longer dialysis treatment. But that's just how we had to manage, and it worked for us. So
yeah, okay. And it was yes, Dave.
See, I think it was needed, because during those days, everything should be done. But now we are better, and patients haven't died because of the reduction of the dialysis time. But they could have died if there were no machines to be dialyzed.
Okay. And then David, you talked about, this is just a sort of practical question really, it's about the issue of food. So in the dialysis units, there were no meals. Was anything allowed to be eaten, or was eating banned? Were patients allowed to drink?
Yes, it depends. There are several hospitals or dialysis units that they allow patients to eat something, or especially if they are in the second shift of dialysis, because they remain at the dialysis units from 12 until 5. So during that period of time, they need to eat something. Not all of them, if the doctors or nurses recommend not to allow them to eat because they can suffer during the dialysis, any kind of effect, they don't eat. But the rest of patients that can eat and it's not a problem for them, we allow them with care, especially if they have a catheter. But they can eat like a sandwich, or even they can drink a small coffee or glass of water if they need. But during this period of time, there is these 3 months, even yet we don't allow them, but we have forbidden in order not to touch everything, in order for the staff not to touch, not to manipulate any kind of food.
And is that still on? Is that still ongoing now?
Yes. In the most of units, it remains the provision.
Okay. Great.
Can I ask a question? What was the reason, David, for not allowing the food? Because of they are removing their mask while on dialysis, or just because they're having other symptoms? That is difficult, or we worried about cross contamination? What is?
Yes, because they remove the mask when they are eating, and also the preparation of the food. We didn't want to touch the food, the dishes. I mean, everything to give things to patients with the hands, even with the hands, they clean them. But the minimum contact with patients and with things that can be touched by staff or the patients. I think it's not. It's just patients got very angry when we told them, and I think it's not very important really, because if you clean your hands and if the meals are protected with any kind of thing that can be removed, it's not very important. But that's a thing that was made during this period of time.
Mm-hmm. Okay. Thank you for that. Reem, you talked a little bit about, and forgive me if I didn't pick up on it, but you talked about the development of competencies. Is that right? Specific to COVID-19?
No, I've mentioned that we had to utilize our BD nurses to help in the hemodialysis unit, because we stopped the clinic, and obviously the patient were asked not to come regularly unless it is important. So they already done the competency, so they were well trained to do the hemodialysis. But we didn't have a specific competency for COVID. Cross training. I've talked about cross training for nurses to work between units, because we had to, when we open extra units, isolation units, we had to open second and a third and a fourth isolation unit just to accommodate COVID. This is hospital-wise, not in renal only. So I was talking about cross training, that they do the basic competency to cover other areas than their scope of service. At one point, we had to utilize pediatric nurses to work in ICU.
Okay.
With minimal training, with the age when it's close, and only in some cases when we had in the ICU. And we utilize the hemodialysis nurses because they have a ICU background in the inpatient area. They can help to relieve the staffing shortage in other ICUs, the new ICUs where we had to open. This is simply, but wasn't competency specifically for COVID. It's only the BBE training that everyone in the hospital was trained early on, how to do the donning and doffing, and we were really strict on that and applying all protection. That's what saved the cross contamination or outbreak among the nurses or among the healthcare worker or and patients themselves. And we have a DBE officer who's responsible. I think David said something around that control the use of DBE, because it was first restricted to isolation units and then some of the ICUs, and we had to assign someone to look after this utilizing this personal protective equipment. Alhamdulillah.
Okay. And Reem, another question's come in for you actually. Do you know the number of infections in KSA and specifically in renal patients?
I have in our hospital, we have at the moment, it's not a big number, like similar to Vienna, we have 6 confirmed, and we have 1 pediatric and 5 adults as of now, and 2 suspected, just of today, suspected cases. We have a dedicated hospital, COVID dialysis unit, that they are transferred to that facilities, but I don't have the exact number, but that's a dedicated hospital from Ministry of Health to cover COVID patients. So they dedicated there. In our hospital, because it's university, we take some because we have some negative pressure room. But yeah, the number is not high, alhamdulillah. It's not, we're not getting out of the medical capacity, and we're utilizing our same supplies, alhamdulillah. Except for BBEs, a shortage, then it comes back and forth. This is just like an international issue.
Okay.
Yeah.
Okay, this is an interesting question which has come in. I don't know who wants to answer it, and maybe you haven't experienced it, but it's asked, if you had a patient who was on dialysis and they had suspected symptoms, would you continue with the session? It's a bit like a question and answer. Would you continue with the session, or would you stop? Or would you isolate the patient? I suppose you can't really isolate mid-session. What would you do? Have you come across that situation?
I can answer. We came across that. It was the first case. The first case we have, it was our regular patient, and it was he was having symptoms, but he was taking paracetamol at home. So when we do the visual triage, he said he doesn't have symptoms. So when he was in dialysis, the doctor, when he started the session, and he realized he suspected him to have a COVID-19. Some patients were in denial, I have to say, at the beginning. They were. We had to educate them that you're not going to miss your session. You have to be clear and just tell us, we're not going to send you home. You have isolation room. So in that case, what happened? We actually terminated the dialysis because it was forbidden room, and we start the dialysis again in the isolation room with all precaution and full DBEs, and it turned, and we take the swab later, and it turned out to be positive. And with the severe symptom the next few days, unfortunately he passed away after a week or so. Yeah, we came across that was our first case, because and then patients were educated that they need to be clear and communicate their symptoms when they come to the triage room, visual triage room. Yeah, I'm not sure if anyone else has it.
Yeah. Okay.
Yes, I want to add another thing. In Spain, in most of units in Spain, or at least as far as I know, if the patient has symptoms during dialysis, we try to not to isolate it because it is connected, but to put distance from the rest of patients, and to be dialyzed only by the same nurse, only by only one nurse to one patient. I haven't understand if you have told Reem, sorry.
That's okay. No, that's helpful. Thank you. Just a quick question for Faith. There's quite a lot of questions now, so some of them you can just say a very short answer. But Faith, the nurses who were allowed to travel to come to work, they were allowed to cross different states to work?
Yeah, Yeah, because we were in dire need for nurses, so they were able to travel. So I know since we were the first area really that got inundated with COVID, these nurses traveled from California, from Texas, and they came to us to help us out. And now they left us and they're going to the other states that are in need.
Okay,
Yeah.
great. And then for anyone who has the experience, in relation to the AKI patients, how many or what proportion or many became chronic patients from the ones who didn't die, I suppose, because there was such a high death rate, high mortality rate. Did many recover back to normal, or did many become chronic patients?
I think I'll answer that. I think a good amount of patients became chronic. But for the AKI, the critically ill patients, they did not do well. But the chronic patients that did come in that were already chronic hemodialysis patients, they did fairly well. But I would say about maybe 40% of the patients that did survive did end up on dialysis chronic.
Okay. Okay, thank you. Did your units have a dedicated nurse who triaged outpatients prior to entering the dialysis unit? Did you have someone at the door waiting to triage, sort people out? How did you manage that entry into the unit, I suppose?
Yeah, can I answer?
Temperature and check, and then there was a nurse there always as well. So, but there was a designated statewide flow coordinator for moving patients across sites as well. Obviously, we never needed to use it, so that was the bonus. I was the designated flow coordinator, so yeah, we were at an advantage. The others would be different. So,
Reem, did you want to say something there?
Yeah, I would say that was very important to have a dedicated one. At the beginning, we didn't have, but because we have specific time for patients to come in the first session and in the afternoon session, but some patients come earlier on and they go straight to their place, and we wanted to prevent that. So we had a dedicated, like was in the picture, dedicated nurse with a full BBE, just waiting, not only for patients, for everybody who's entering the unit, to have to screen them before they come into the unit. And other area, we increased the visual triage area from like plus 6 to 12, then to 15 area around the whole hospital, main entrance, other units. And when we had shortage of nurses, we utilized the medical intern and the nursing intern. That they sit at this entrance and ask the question of the patient and do take the temperature with the thermoscan to make sure that everybody. And it's proven effective, because some cases that we have maintenance and other they have symptom, and that's the only place that you spot them before they come and be with the patient or in the area where the patient is there. So it works well.
Thank you. Back to you, Fina. Someone's asked a specific question. So isolating potential COVID patients and those returning from Melbourne hospitals is proving an issue with only one isolation room within our unit. Any ideas?
Oh. That is interesting. I suppose what in the unit I'm in, we have two, in the dialysis unit, we've got two units. We've got one acute unit where the inpatients were, and we've got a chronic unit in the hospital. In the chronic unit, we have two negative pressure rooms, so we were at an advantage. Our hospital is single patient rooms as well, so they're all dialysis. Well, there's a number of the rooms that are dialysis capable, so we didn't have issues as such like that. When you've only got one isolation room, I think it's probably looking at things like what Faith did by reducing time to try and fit people in when you're at that level. Our patients were, if they were suspected, which we did have a few, they were told to wait in the car and ring us, and then we called them in and test them as they came in. And we use our rooms for that purpose. But I really, for one isolation room, I I think how ours worked was because we had a dedicated state hospital in South Australia. We were the only hospital dealing with COVID, whereas in places like Melbourne, in Victoria, they have all of the hospitals are dealing with it, where we were the first port of call. All of our patients went into, when they arrived internationally or from Victoria, they went into hospital, or not into hospital, into hotel rooms, and were made to isolate for 2 weeks. And that's still happening. So nobody can enter South Australia or even any of the states without going into 2 weeks isolation anyway. So I would, it's very hard to give a suggestion for just one room unless you're actually looking at the service as a whole and maybe work between other units to try and develop something better as a plan.
Okay. Great. So there's lots of panel, I let you know, lots of excellent meeting coming up on the contact boxes. So people are enjoying. So thank you very, very much. Just a couple more questions. To what extent was there any patient consultation strategy development? So I suppose this question's around how did you consult with patients? Were they involved in the planning? And I'll ask you that bit first. Did you involve patients in your planning around COVID? Was there time?
We didn't have time, but obviously as we put in things in place, there was one-on-one communication with every single patient about it. So
Yeah.
But again, ours is probably a very different experience to everyone else. So they were seeing what was happening in the rest of the world before it got to us. So.
Yeah, and the question actually goes on to ask, was communication maintained during COVID to alleviate patient fear and anxiety? So I think that was the important bit, wasn't it? That one-to-one and very open communication.
Certainly our Kidney Health Australia and I think Kidney Health New Zealand were holding webinars as this for patients, and they dealt with different areas like CKD, like transplant, like dialysis, and they went through advising about the special things. One of the biggest things that was happening here was people weren't attending their appointments, they're missing their appointments or missing blood tests, therefore, especially those in the CKD phase, so they were actually neglecting their health, and that was why those webinars came up, and they were continually, and they're still going on. They're not as frequent now, but they're still going on.
Okay. A question to everyone, particularly those, I suppose, who were busier with COVID. Whilst dialysing COVID patients, COVID positive patients, did you experience excessive clogging of the circuit, possibly due to increased inflammatory molecules or increased hematocrit? And if you didn't, were there any other treatment-related challenges? Yeah, do you want to go on that, Faith?
Yeah, we did. They were clotting the circuits a lot. Their blood was very dark. And we just kind of changed the setup and just kept moving and tried to do the best that we could to dialyze them.
Okay.
So,
and were there any other symptoms that were recognised, any other difficulties because the patient had COVID? You, David, as well?
For us, I think for the critically ill patients, it was more their position. So a lot of them were prone, so they had temporary access. So it was very difficult to dialyze. You know, we didn't really want as nurses to dialyze a patient that was laying on their stomach. So we had to kind of coordinate with the proning team to flip that patient back over so that we could dialyze them. So it was a lot of coordination with a lot of different areas within the hospital to make sure that we could safely dialyze those patients.
Okay.
A problem that we have not found is not the temperature. The temperature control is not very effective, in my opinion, because not all patients have 35 degrees. So it's in the triage. It is important. It is of course necessary, but it is not a good filter to detect patients with COVID. So it's a problem to detect that during the triage. That's because in the beginning, everyone with more than 37, but at the end, a lot of patients that have suffered the COVID-19, they didn't have any kind of high temperature.
Mm-hmm. Okay. Okay. So back to staff. So Faith, in particular, you talked about staff working 16 hours a day, 6 days a week. You all would have had staff working extra hours. How did you help staff and help deal with the emotional fallout from all of that? Because I'm sure it was terribly stressful for staff wearing PPE as well.
Yeah, it was definitely stressful, and even for me as like the nurse manager, it was emotionally stressful because you're worried about these patients and you're also worried about your staff. But I have to say I have such great staff and everyone really works together and they look out for each other. So it was like no gas. They were like, we're here, this is what we're here to do, and we're gonna work as a team. So, but once we got the traveler nurses, I tried to give my nurses a little bit of a break as well. But the hospitals also had, you know, support lines for the nurses to be able to call. ANNA also had a lot of, you know, mental well-being and emotional support tools on their website as well for the nurses.
Mm-hmm. Okay. Do you think they accessed it?
Oh yeah, of course. I know I did too. So
All right. Okay. Good.
we just have little huddles too and kind of just talk about like the day and how everything went, and everyone kind of was able to express themselves, and I think that's the most important, that their voices are heard.
Lovely. Okay. How did COVID and the restrictions affect patients who are used to doing self-care or shared care within your units? Was it abandoned? Anyone want to answer? Do you all have shared care in your units? Maybe not.
We didn't, but fortunately, one of the areas that we moved our patients to when we cleared a shift was to our home training unit, and we now have now got over 10 patients that have done shared care since the COVID, and we've got more people taking up home dialysis treatment as well.
Okay.
We've started
Sorry, Fiona, what did you say there?
We've started a program with the shared care, so yeah, a greater program because of COVID.
Okay, and then a question from Macedonia, who this person has said you were all amazing. So thank you very much, Gabriella, for that feedback. She's got a couple of questions which we can answer quite quickly. Do you all now have a negative pressure room for COVID positive patients? Who does? 50%. Okay. And another question, do you wear suitable face masks every day for every hemodialysis treatment in every facility? Who does? So masks are compulsory in Spain and Kingdom of Saudi Arabia and in the United States, but not in Australia yet, you know. Okay. Pediatric patients. Anyone treating pediatric patients? Reem, you are. How was the approach? Were they more scared? Were they frightened?
Yeah, they were actually. So we have a separated area for pediatric, and that's the one we allow their relative or the mother or the father to be accompanying them. Otherwise, we are not allow anybody inside. They were scared. They were wearing the mask. They were not listening sometimes. But recently, unfortunately, we have one positive case. He's very brave. He had a video already. He recorded a YouTube channel with one of our doctors, and about his experience in general and what he wants to be. It's amazing. And he was really brave. And because we have a glass in the negative pressure room, we communicate with him. And I have to say the mother were more scared. They were worried about them. And he was asymptomatic until now. It's only because there was positive cases in the family and we had to consider him as suspected. And when we did that swab, it turned out positive. But he's asymptomatic and he's okay. But kids are really brave, I have to say. They are understanding. I don't know if it's because they're chronic or they are. In my unit, we have about 12 pediatrics, and they are following what we are telling them. Actually, if he forgot, we tell him put the mask, disinfect your hand, and they're interesting to follow it actually.
Reem, could we ask that you share the YouTube video link, because I'm sure that lots of people will be really interested in having a little look at that and get his views up. That would be great. Thank you very much. Last question's really, really quick. Well, it won't be quick, but we'll make it quick. But it's the last one I want to squeeze in, and I really, really apologise to all those other people who've put questions in and we just don't have time to answer them. But it's about ICU and admission into ICU. Was it difficult to get your patients into ICU where you needed to? Or, you know, it's a bit of a battle, I suppose, when you've got a pandemic. Did you feel that they weren't given priority, or were they given priority as equal priority to any other group of patients? Because there was a worry that, you know, renal patients would be heavily impacted by COVID. So was it okay? Yeah.
The question, you mean other cases who need ICU or the COVID patients?
So patients, renal patients who needed ICU admission, could you get them into ICU okay?
For us, we have ICUs with dialysis machine and CRRT. So we have, so they usually can be admitted if they are critically ill. They transfer from our inpatient or acute area to the ICU, and they will continue their dialysis session there in the negative pressure room, because there is dialysis nurses and a dialysis room dedicated in ICU for renal patients.
Okay.
Yeah. So.
Okay. All right. I'm going to stop there, and I'm going to say thank you so much to all of our panel, Fina, David, Faith, and Rima. We could not have done this without you. It's been a really, really intriguing and such an interesting webinar. As I say, the recorded video will be available on the EDTNA ERCA website and via YouTube. There will also be an evaluation that we would really find it so helpful if you could complete that. So it's about satisfaction in relation to the webinar, and it will pop up on your screen as you leave the webinar. So we plead with you to complete your evaluation, because it will help us in making improvements going forward. So it'd be really helpful if you could do that and just help us to plan things more appropriately. And if you wish to suggest topics, we're very open to that too. So I really hope that you've enjoyed this webinar, and I also really hope that you'll be joining us for future webinars as we arrange those in the coming months. Thank you, everybody.
Thank you.
Thank you.
Thank you for having us.
Thank you very much.
Thanks and bye.
Bye-bye.